So, welcome to the TechPulse Healthcare podcast. Today, on our fourth episode of our second season, we're actually managed two seasons now. So, into year two we go. But we have Lesley Soden with us, who we'll introduce shortly, and of course, my co-host, Jonathan Provetz.
Hi,
Hello.
everyone.
Lesley, thanks for joining us on our humble podcast. We're honored to have you with us. I was looking through your profile and just trying to. I always try and get an understanding of where people have been and where they're at. And it seems like you spent a lot of time in the NHS, quite a number of years, and then you've kind of taken a detour and started off on your own. Can you tell us a bit about that and what you did before and what you're doing now?
Yeah, sure. I've been a freelance consultant now, running my consultancy called Securus since 2023. So I'm just coming up on my third anniversary of full time of leaving the NHS. But prior to that, I worked at a health innovation network in South London, the original one, as a program director for innovation. So providing that guidance to innovators and also running a number of other as it wasn't then AHSM programs. So I had a sort of quite a large portfolio, but mainly around working with the industry and things like the medtech funding mandate. So really interesting work. I was there for about 7 years, hosted by guys in St Thomas's. I'd never ever sort of ventured into digital and tech. Before that, I worked in strategy and business development in an NHS trust, and we would both at a mental health trust and a community trust, we would scratch our heads and go, does anyone know an app we could throw into this tender or this business case? It was literally always very last minute. So when I saw the Health Innovation Network advert, the main thing that I got excited about was the job title, which was Head of Innovation. I had no idea what it was about. I just looked and I thought, oh, sounds a bit exciting, doesn't it? I'm quite fed up with nothing happening in the NHS working. So I went off there, which was sort of quite a big, steep learning curve, learning about commercialisation and the sort of access into the NHS market, because I knew it from the other side of what the NHS needed and all of the processes, etc. So it was really, really interesting job. And the interesting part about it was that you got to meet a lot of innovators. So learn about all the latest AI, digital health, medtech, biotech. It was very varied. UK companies from overseas, and it was quite light touch, the work that we were doing, so very much advice and guidance. But now it's partly one of the reasons I left. Honestly, it was a bit of frustration with the low adoption, very slow, very bureaucratic, very hierarchical, and I knew I could do more with companies. I could have a lot more impact. And I could probably say, actually, since leaving the NHS, I probably have had more impact because I don't have a boss as such. But also, it's been really interesting. I collaborate with a lot of other consultants. I work with my former chief executive, Tara Donnelly, quite a lot through her consultancy, which is great because I miss working in a team. And I've also got quite a varied client base, and it's project based, so it never gets boring, and it's always very cutting edge technology. So that's partly why I left the NHS, and it sort of felt the right thing to do at the time.
Wow. Yeah, it's quite when you hear about people, I did something kind of similar, but maybe not as big a jump. But it's always a risk involved. You're leaving something. NHS especially seems like a really cozy, secure place, job for life type thing. So to give that
Yeah,
up is it's quite something.
it was. I went part-time, actually. I was fortunate that the Health Innovation Network did let me go part-time to test it out, because someone very wise at my workplace did say, just give it a go. I was on a good salary. I was quite senior. And so, yeah, the hustle is real, but actually the benefits outweigh. I thought I'd be a bit more worried about leaving my cozy NHS job.
Hmm.
But actually it's sort of worked out. There's always work. That's what I've sort of got a mantra. Something always comes up. And it does. So yeah, it's been successful so far.
Wow, that's very good, and it's good to hear you collaborating with you were saying with the previous. That's really key as well. One thing that I've like, 'cause it can be very lonely
Yeah, there's
when
some.
you're in.
There's some great sort of like those ecosystem partners, and there's a lot of other consultants, and we sort of you refer in between. You might say, oh, that client doesn't, I don't really have the skills for that. So yeah, I've been pleasantly surprised actually how collaborative it has been, considering it's not, we don't have a, you know, if you're in the NHS, you have a duty to be able to collaborate and partner. So it's quite a nice sector to work within, because people do seem to support each other.
Well, that's really interesting. I always find as well that you know the highs are quite high when you're on your own, and the lows can be quite low as well. And but you're responsible for it yourself, right? It's one of your hands.
Yeah. It's, I mean, I didn't realize, well, I knew I was always good at hustling, because that's what I did. I did business development in the NHS, so I could always secure funding. That was my role. But in some ways I quite enjoy it. It's good fun. You know, you win the work, and then you have to deliver it, and then you've got a result, and you can see a product, or you know, it's a piece of work that you've delivered. So but it is, I mean, it's hard, you know, dealing with tax and everything else as a freelancer is so that's always, there's a lot of business development, put it that way. There's more business development than I thought there would be.
Yeah, the sales aspect is heavy. So if you were just going to describe what so is that pronounced it Succoris, is it?
Securus, yeah.
Well,
So
how did you come up with the name?
so I went to, this is quite interesting one, because I've just trademarked it actually, because there is a company in Australia called Succoris Psychology, who I went to an agency in Amsterdam, and they ask you what's your business about, and then they sort of merge it together, and that was the name that came up. So I hope that company didn't sell that name off to an Australian company. But yeah, I'm trademarked now in the UK, so that company can't work. And I'm UK based. Most of my clients either UK based or looking to enter the UK market. So yeah, it's a name. Didn't realise it was quite unpronounceable it was, but you know, that's one of those things.
And if you were just going to say kind of briefly, what does your, I know you've kind of mentioned it, but what does your company do? Someone would say, what would they come to you for?
Yeah, so it's mainly around commercial and business development for either scaling or adoption in the NHS or the UK health market. So I've been getting more involved in the sort of B2C and the private provider space and insurer space. But my expertise is within the NHS. Also, sort of some of my bread and butter is bid writing. So bid writing, grant writing, a lot of NIHR and Innovate UK grants. But they're not within the commercial. It could be about very early stage, work with quite a few spin out from universities. So looking at their go-to-market strategies, their business plans, writing business plans for them, what's their revenue projections, who would pay, mainly the question that's asked, who is it going to pay? Is it worth the risk? Is the NHS market that they want to go into? I'd say 99.9% of the time they do want to pursue it, because it's a brand. It's an international global brand that is known, that if you have an NHS contract, is a sign of quality of that innovation. I've just had one client that said it's not worth all the resources. It's quite resource intensive. So yeah, so that's mainly what it's very much around looking at, is the NHS market, is that something? If so, who would pay for it? Who's going to make the savings on it? How does it fit into a clinical pathway? How disruptive is it? Very similar to sort of the assessments that we used to do, or they still do at the Health Innovation Networks. An assessment of, does it meet a need? Is there a budget for it? Is there enough savings? And it's quite interesting. I thought when I left the NHS it would be difficult to get some of that information, but actually there's sort of other sources you can find out what's going on, from the policy side. LinkedIn is a great place that I find information that's then validated, board papers. It's this sort of usual places to find
with and sorry, just one little addition with bid writing and things. So you
Yes.
with Innovate, I've done some on, I think maybe on the other side, where assessing people's bids. So you've helped people
I've done,
submit
but I do
things.
both. So I sit on an NIHR committee, the I for I Connect, but I also write NIHR.
Right. Yeah.
Hugely, I mean, it's hugely competitive. It's very difficult to get one through. So hence why I'm on the committee, because I want to find out
it's a
how the
bit of an art.
decisions are
Yeah,
made.
yeah. It's a bit of an art. It's quite interesting. Yeah, because you see one that's well written. It's very. It doesn't. When you look back at it, it's not that hard. Because I look at it and think, oh,
No.
that wasn't hard. Why hasn't everyone done that? But it is when you're blinded by all the millions of pages.
Well,
I can see.
you've got to hit all it's a big committee, it's a big panel.
Yeah.
You've got to hit all of their interests
Mm.
and all of um their biases that they've got around. Is it actually needed? Is this something that we should be funding?
Yeah.
So it's never going to be an exact science to pick the best applications. So you could
Yeah.
write a beautiful application that's really cutting edge. But if you've got someone who's skeptical on the panel and tends to be as a clinician, they can sort of sway the sort of argument within the decision-making process.
Do you think, Lesley, it's interesting because I'm sort of on the clinical side, and I get the sense that there's quite a bit of suspicion
Yeah,
from within the NHS
there
about
is.
being sold to.
Yes.
And
Yeah.
how do you sort of overcome that and help trusts to recognise that actually there's a load of people out here who are trying to help. Yes, they're going to make money, but they are ultimately trying to help.
Yeah, I mean, I think I'm aware because I was a bid writer in a community trust, and we'd lose services to private healthcare providers they were KUK, Virgin Care, that sort of providers. So I get the mistrust of the private sector because they have had their fingers burnt where staff have transferred over or they've lost services. So I understand where it's that view, oh, we're being privatized. This is a very strong sort of 15, 20 years. But and I was quite surprised actually when I went into the Health Innovation Network. There's a very clear argument that both innovation, it may come out of a university, out of a research, you've got to spin out and they've got to commercialize. So it's not, we don't have the skills and expertise to develop innovations internally within the NHS and commercialize and make them sustainable. We're not necessarily set up for that. But also the other part is the argument that I've always used with any of the clinicians that I used to work with is if you are improving that the economy, so you are making a company profitable, the tax goes back into the NHS. So it's a big old loop. There's lots of different arguments for it, but it's also the understanding that people they're very wary of private sector and coming in and taking over the NHS, which is, it's a national treasure, isn't it?
That point about sort of internal innovation is a really interesting one. Are there any examples at the moment of any trusts where they've got a sort of entrepreneurship model where they do develop stuff on their own?
Yeah, there's a few, like Guys and St Thomas's is one that immediately springs to mind because I did work very closely with their commercial team, and they have, because they're also very strong on research, so they would have a leading surgeon in orthopedics, for example, developing something, and then it's getting spun out of Guys and St Thomas's, it's getting commercialized, or there's money that's put in. There's a few others around the sort of Oxford, Cambridge area as well. So it does tend to be tied to that university base. But there's also, I come across very small trusts who I always think are innovative, and they don't shout about it. So they do try lots of different digital and tech solutions, but they're not necessarily the ones that are shouting the loudest about it. They're just taking that risk and going for it. The sort of internal development, I think, is useful if there is a need and there isn't anything else on the market. But normally, an innovation, you need to do a proper competitive analysis to figure out, is there already something out there? Because it might be a doctor that's got a great idea that they've seen a gap, but actually there might be already a solution that's out in the market. So really you should be looking at, does that solve that problem rather than reinventing the wheel?
I'm with you. So in terms of solutions then, what kind of, have you got any examples of any surprising success stories, things that landed on your desk and thought this is never going to happen, and then actually somebody bought it?
Oh, yeah.
I've put you on the spot here.
I can't think of one that comes. Let me think of one that comes to mind. I've seen, not necessarily where they surprise me, because to be honest, when I assess something, I normally know if it's got potential. So rarely see something where I think, oh, that's not for the NHS, and then it does well. I've seen ones where it's been a very slow adoption, and I've probably learnt the lessons of what they did to be able to get wider scale and adoption within the NHS. And it is, to be honest, it is normally the ones that have got investment raised, large investment, because you just need the resources to be able to both collect the evidence you need, run the clinical trials, run the health economics trials, then go out and sell into the NHS and sort of work in a collaborative way. There's ones that I get disappointed when they don't get, there's probably more I get disappointed when they don't get adopted and they don't achieve that, because I've seen the potential. I mean, the one, I suppose the one that I always use as a case study was so S12 Solutions. I saw in probably my first month or two in the Health Innovation Network, and it was digitalizing the Section 12 psychiatrists that you need to be able to undertake a section of a patient. And I just come from mental health trust. It was a huge problem for us. Problem with finding the S12 psychiatrists, getting them there in time, because they're then sort of stuck in the system, the patient, and the social worker, etc. There's a lot of people, and just being able to digitalize that process. So when the founder, Amy, came and spoke to us, both myself and the head of mental health went, well, that's a huge need. We know it's a problem. That's a blocker in all of the mental health pathways. It's a huge problem. It's a problem for the police. It's a problem for social care. It's a problem for everyone. And I think when she exited, they were in the majority of being used in the majority of mental health trusts, because it was a need. And it was also a founder that was a social worker, so understood the problem, and then just sort of worked really hard to get it into all of those mental health trusts. So that was probably more of a success. The one that I'm probably the most astonished hasn't been scaled is Sleepio. If I'm going to say one, they got a positive, nice appraisal. They were all over the Times saying this will now be, because it's a CBT sleep app, so it takes you through a program. I've used it; it's very good.
I think I've used that as well.
Have you heard of it?
Yeah, isn't it like some Scottish accent type thing? Is that the one?
So Scotland bought it. So if you live in Scotland, you can get access to it. England's patchy. It's various places that you can get it. So there's a postcode lottery with it. But it's one of those ones where it was, the NICE was saying this should be used, this should be funded, but it's still very fragmented as far as I know. And that was the one where I went, well, you could do everything that you meant to do and you still don't get that large scale adoption. And it's not fair on patients. It's not fair, me living in West London, I can't get the Sleepio app. If I was living, I think in sort of parts of Oxfordshire, maybe that's where they could get it. Yeah.
Yikes! Yeah, it's like you say, it's a postcode lottery, isn't it? And it's never a case of selling into the NHS, is it? It's just this massive collection. It's like a coral reef of collections of organisations, and
yeah, and I think, and also if you're a company and then you get an ICB or a trust interested, and they get very excited, and then they go, oh, by the way, we've got no money.
Yeah.
So, I've got a client at the moment that's continuous, and they'll get 1 year projects and then there's no money. And it's, it's very, I think it's very difficult if you are trying to sustain your company for the NHS to be your sole customer. When I'm talking about the NHS, yeah.
So in a couple of sentences then, what kind of would you say to founders who are maybe on the verge of giving up? What would you say to them?
I always, because my number one question is, why do you want to get NHS contracts? Because then that will give me a clue as to whether it's worth it. So if it is to get the NHS brand, if it is because they know that their innovation is needed in the healthcare system and they've got evidence to show it's needed in the healthcare system. There's a lot of founders, it's very, the passion, enthusiasm they've got for it. But the main things I would say is you need to make sure you've got your clinical evidence, you've got your real world that it can be used in the real world and that it's accepted, and your user experience and acceptability. A lot of companies, they do all of that because that's part of their process. They will look at user acceptability. They don't share that information with any of their potential customers. So there's that. There's also having flexibility within their contracting. So don't just assume you're going to get you're going to license it, because there isn't the budgets for it, and you've got to share that risk. So looking at different ways that you can contract risk gain share, outcome based. There's lots of different examples, but there's not much evidence out there that has been tried. I mean, I've got a few that I've come across and that I've been involved with, particularly around risk gain share. And then the other thing is your sales workforce. So I often come across amazing founders, really passionate, everyone loves them, and then they recruit a very hardcore salesperson to go and try and sell in the NHS. And you probably know what that's like when you've got it doesn't work. It needs to be working in partnership, it needs to be co-design, it needs to be going to them in a much more collaborative way. You're not selling widgets into an industry, you're selling it to people, a sort of a new way of delivering healthcare. So that's another bit of advice. When founders don't take that advice, it is quite disappointing. I mean, the other parts that sort of is around the deployment. You've got to put enough resources and time and speak to the right people in your deployment and co-design deployment. So when people talk about co-design a lot of the time, they're sort of talking about the co-design of the innovation. It's not. You've got to co-design that deployment. How are you going to monitor the impact as well? Because if you are looking that you've got a 1-year contract or you've got paid pilot, you've got to show that it's worked. And often they're too worried about upsetting the customer. So you've got to get that baseline, and you've got to get data that's been monitored, but data that's already being collected. So you probably know there's so many performance indicators in NHS organisations that you get monitored against. And often innovators don't even look at that part of the board paper. They don't look, if it's a workforce solution, is it reducing sickness levels? Is it reducing bullying and harassment? Is it what? They're all there. It's all there. All that data's there. You just need to give a baseline, and then you can demonstrate the impact against it. And the part that's quite difficult is at a national level, you'll be talking about the sort of nice health tech evaluation, health economics, the quals, and how that. Whereas a finance director, unfortunately, what they want to look at is the bottom line. Are you going to make me those cash savings? Are you going to make my performance indicators look better? That's what a chief executive or a finance director is looking at. Is it going to improve patient care? Are we going to become more efficient? So it's really the other part. I always say, get this key people particularly within a trust, that you need to get involved as soon as possible. So don't just rely on your clinical champions. You need to involve the information governance team, clinical safety. Procurement is often a blocker. So they might get so far and then they just get blocked by procurement saying, no, it needs to go out for tender. I mean, this is what I often help companies with, is procurement frameworks. So doing applications for procurement frameworks, because then they can just call them off that procurement framework. And the other part is just learn how to write a business case. Because if you're expecting your NHS lead to write that business case, and they're often long, it won't be at the top of their list. So learn how to write a business case, and they're quite general. And then the other part is make sure you've got good customer service. I often get that, we've got someone there's an email that you can contact, and it's like you need your customer service to be longer than 9 to 5 Monday to Friday. You need to make sure that if there's a problem, because the NHS works 24/7, it doesn't work 9 to 5. So that's another one. Lots and lots more that I would say.
Yeah, a lot of that's actually quite familiar. So the work I've done is kind of a bit more broader. So it's not just NHS, but in fact, not a lot of NHS. It's quite that's a huge area. But maybe with enterprises and more corporate. But it's the same story.
Yeah.
Where you got to know your stakeholders. That if you're going to implement something, you got to know who the key people are and get them involved early. and know what
find
they're
out what
looking
their
for.
hooks. It's finding out what their hooks are.
Yeah,
So
absolutely. Yeah.
the nursing director is very different, got different priorities to she will be asking, are you going to put more pressure on my staff, my nursing staff, my allied health professionals? The medical director, is this going to be interesting for my doctors? Is this something that they can do research around? It's lots of different hooks, and it depends on the trust, and it also depends, look at those stakeholders, look at what the finance director, look at, and I would also say, look at their deficit, because I've just come back from a client that was sort of saying there's a load of ICBs that's interested. They keep saying they've got no money. So I've just looked, they've got huge deficits. And it's like, I think I wouldn't put too much effort into those ICBs. You need to go after the ICBs that are where you've got, and being creative with their funding as well. And they've got a risk appetite. So a trust with 50 million deficit doesn't necessarily have the risk appetite. Sometimes they do. There are a few I know that will still do that.
Yeah, yeah. Wow, that's so interesting. Yeah, yeah.
Mm-hmm.
Yeah, it's really, really interesting actually how much how similar it is. It's just different people, different characters, same story. People don't start with problem definition, just start moving into things, stakeholders, who's giving you the money. Look at who they are. You've got to, and like you were saying with writing the business case, the people that are going to look at it, you need to know who they are. You need to know who they are at the beginning. If you wait till the end to figure out who they were, you've done all this work and they want something else. And it's like, well,
that's if you don't involve like information governance, if you're integrating, or if there's any exchange of data, that can take quite a long time.
Yeah.
And you've got varying degrees of flexibility within information governance leads. So you get them involved as soon as possible, because otherwise that could delay 6 months to 12 months.
Yeah, because sometimes there's a feeling that with difficult people, just leave them out, right? But the problem is that comes back and hits you later on even harder. So it's better to get them in early and win them over. Just find out what they want, what they're looking for, what their fears are.
But also, their role is there for a reason.
Yeah.
They are there to either protect the trust or to protect patients. And from a reputational point of view, you want to use that expertise. You want to make sure that you've got a safe deployment and that it's successful. So it's not if you avoid those people, you need to just work round. You need to work round and understand what their requirements are.
Yeah. No, really good. Thanks. And just last question, really. What over the next, if we're going to say 5 years, 10 years, what's your roadmap look like? Where are you going? Are you planning to carry on with this, or doing nothing?
Yeah, I mean, it sort of goes up and down, doesn't it? It depends on how. I mean, I have a number of interest areas. I still feel very passionate about the NHS adopting innovation, because I just see so much of it getting missed out on for improving patient care, and it's quite frustrating. But my sort of personal interest around women's health, and particularly about using data that's collected through wearables and some of the emerging technologies that can monitor hormone. Mm-hmm. So the hormone levels that then impact upon some of those more prevalent health conditions for women, and then being able to empowered with that data and that data to be used. That's sort of my interest from a business perspective. It's interesting, isn't it? Because I like working on the projects that I work on and the mix that I work on. The part that I find quite interesting is some of those companies that are quite small startups, being able to continue to work with them so that I'm not just sort of picking them up and working with them and going, that there's a long-term relationship of actually getting and supporting them into getting them adopted, rather than that sort of early stage where they're looking at where the payers are and where their commercialization is. So that's for me. What I quite like doing is lobbying, because I don't work for anyone now. So I have been known to sort of put a bit of pressure on NHS England when I can see that data is showing particularly variation or inequalities. So inequalities between different ICB areas. So sort of from a personal point of view, I mean, that's not my paid work. That's my sort of what I would like to see improved. So it's a sort of I suppose it's a mixture, and it's having enough time to actually make the money and to deliver the work.
Yeah. No, so sounds really interesting. It's nice to do things that are fulfilling as well, and on the seeing change happen as a result of the things you do. So sounds really
Yeah, I
good.
mean, it sort of comes back to what I was mentioning before, that the flexibility I have is that I can connect people without having to get permission. So I've probably done more of that connecting people together than previously, which I can understand why sometimes people are restricted when they're working within an NHS organization. But I do think that needs to change so that you can get innovators in front of the right people. That's sort of one of the main things. They're not selling to them, but it means that policymakers and people with holding budgets are actually finding out about some of these innovations. Not going back to when I was in the NHS organisation and we're saying, does anyone know an app from SK? That was literally what we used to do, and just sort of like be Googling what an app would be, and then sort of, approach that company rather than doing, I mean, we didn't have time to do a proper market analysis and looking at what's out there. So yeah, I do hope that improves in the future.
Yeah, cool. Well, thanks very much for your time. It's been a real pleasure.
Yes.
Learned a lot. So yeah,
Thank you
thank
for
you.
inviting me.
Yeah.
Thank you.
Great stuff. Thanks very
Thank
much,
you.
Lesley. Lesley, are there any kind of websites you want us to refer you to, in case anyone's interested in following you? You're on LinkedIn, aren't you?
Yeah, I'm on LinkedIn. I've got a LinkedIn newsletter that
Yeah.
people can subscribe to. So it's weekly, the Securus Standard, and also my website, which is www.securus.com.
Cool.
Fantastic.
Thank you very much.
Good to
Thank
talk
you.
to you. Take care.
Bye.